Good morning. I will call the September 27th, 2023 Board of Health meeting to order. The first thing on the agenda is that we are going into executive session for 30 minutes. Welcome back, everyone, and thank you for your patience. We're going to move ahead in today's agenda with introductions. Yes, Ms. Smith,
Okay, we do have two staff members, so we're going to introduce those first.
So this is Jackie. She started with our DOH or our outbreak team with COVID 2 years ago. Then went to environmental health and has now come back as a regional coordinator. So I'm very happy to have her back on my team, but she's been involved for 2 years. So a little background on you. Yeah.
I went to Central Washington University, got my degree in pre-med. I am enrolled or going to be in school for Arizona State University next spring to get my master's in public health. And I've been born and raised in Yakima, so happy to be a part of YHD.
welcome.
Yeah, so good morning. This is Ariana. Ariana is moving over from after previously having worked at Yakima Valley Farm Workers Clinic. She'll be working within the breast and nipple health program and bring very valuable experience, having also worked within that program at the Farm Workers Clinic. So we'll be getting a good insight into how the program works at the clinic level as well. Did you want to share a little bit about your background?
Yes, so good morning. I graduated from University of Washington with my Bachelor's of Science in Public Health. I too want to pursue my MPH, so that's in the works. But yeah, I'm just very happy to be a part of the team, get to know everyone.
Welcome. Thank you.
And then we have some guests in the back, so you want to introduce?
Hi, everyone. I'm Dr. Jillian Zuckerman. I'm a family medicine physician at Community Health Central Washington.
Hi, I'm Nushin Aflakian. I am one of the first year residents at Central Washington.
Hi, everyone. I'm Brianna. I'm a nursing student from Heritage University.
Hi, I'm Ray. I'm also a nursing student from Heritage University.
Hi, everyone. I'm Daniela, and I'm also a nursing student from Heritage.
And if I may, Jackie's an example of a staff person who has supported us through many initiatives, but also has been cross-trained. So the opportunity for people to be prepared to move quickly into new position is one of the things that we've been working on, and that's why we value people like Jackie coming.
All right, welcome, everybody. Next is public comment, Mr. Ida.
And there were no public comments submitted. I don't know if any of our guests have public comments.
Right, thank you.
So this is the opportunity for you guys to stand up if you ever prepared comment.
Okay.
Okay.
Yeah.
If you have a comment, please stand up.
Hi, I'm Brianna Soto. I'm a Heritage University nursing student. I'm a resident of the Yakima Valley. I've lived in Wapto for 20 years, nearby our cities like Yakima, Hera, White Swan, Toppenish, all with an increasing drug and substance use problem. I originally had a speech prepared with facts and statistics, and I was going to talk from the heart, but I'd probably lose my train of thought. So instead, I wanted to share how placing Narcan vending machines in the community can save lives. About 4 years ago, I lost 2 friends to drug overdose, and I still continue to hear of stories of these tragedies happening. The statistics hit close to home because in 2016, as a freshman, one of my friends shared with me he did not want to become another number of the alarmingly increasing statistics. At the time, I did not understand his concern. In 2019, I received a phone call that he had passed away from an overdose. He had taken drugs that were laced. Laced refers to the process of mixing drugs with other drugs like fentanyl to make them more potent, frequently without the knowledge of the person using it. The people with him felt powerless to help him because they did not have Narcan. My friend was left alone to die. And it was too late by the time emergency services arrived. I never got to see him graduate, walk across the stage, or even see. This is why I'm passionate about providing access to Narcan to community members or anyone with physical statistics in one part.
We are very sorry for the loss of your friend, and thank you for sharing today. Anyone else?
Hi, my name is Ray Park again. I'm a senior nursing student at Heritage University. 7 months ago near downtown YMCA, I performed CPR on a man who overdosed on an unknown drug. He had used up the Narcan spray that he had, and his partner was yelling Narcan around the neighborhood in a desperate attempt to save his friend's life. He had no chest rise and was cyanotic. With CPR, his color returned, but what he really needed was another dose of Narcan to reverse the overdose. In 2021, according to the National Institute on Drug Abuse, there was 106,000 deaths related to drug-involved overdose. With a Narcan vending machine, we can prevent situations like this from occurring time after time again. By decreasing the risk associated with drug consumption, it will reduce the number of quote unquote frequent flyers in the emergency department, decreasing the overall patient load, allowing the nurses to provide quality care, which leads to better health outcomes for other patients in the ER. We can prevent needless deaths from occurring in Yakima while improving health outcomes at the same time. This is why I want everyone in this room to consider this decision. Thank you.
Hello, everyone. Once again, I'm Daniela Torres and I'm a family student at Heritage University. I understand that some may be divided on what it takes to help those facing addiction, but it is clear that it is a matter of life and death. With it being known that there has been a 28.4% increase in drug overdose deaths between March 2022 and March 2023 in Washington State. And in Yakima County in 2021, 98 residents died of a drug overdose, representing a 34% increase from the 73 deaths reported in 2020. When someone is overdosing, every second counts. Once respiratory arrest sets in, the likelihood of dying increases, but it can be preventable by the timely administration of naloxone. Increased availability can lessen fatal overdoses, healthcare costs associated with emergency room visits and hospital stays, as well as a psychological pain associated with losing a friend or a loved one to overdose. Increased naloxone access is actually supported by a large number and variety of organizations such as the World Health Organization, the American Medical Association, the American Public Health Association, and the National Association of Boards of Pharmacy. Implementing these machines throughout the community allows more people to access Narcan in a time of need without shame and essentially saving a life. Most importantly, every individual, regardless of their circumstances or struggles, has inherent value and worth as a human being. Addiction does not diminish or negate a person's intrinsic worth and the potential for growth, recovery, and contributions to society. Every person deserves compassion, support, and the opportunity to lead a fulfilling life. Naloxone alone will not fix this crisis, but it is a start, and that is why I hope you all continue to consider this decision.
Thank you. Is there anything else?
No other public comments?
Thank you. Then we will move to the consent agenda. And items listed below are considered routine of the board and will be enacted by one motion. There will be no separate discussion of these items unless a board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence on the agenda. Would you read it, please, Joyce?
August 30, 2023, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in August 2023 in the amount of $964,664.67.
Does any member of the board wish to remove an item from the consent agenda? If not, I then entertain a motion to accept it.
Move to accept consent agenda as presented.
Thank you. So we have a motion and a second to accept the consent agenda as read. All in favor, please say aye. Aye. Any opposed? Thank you. We'll move forward. Motion passes. Next is the Yakima Health District Spotlight on overdose prevention updates from Lillian Bravo.
Thank you. So as the title implies, today's will be a 2-for-1, so we'll be doing a spotlight, but it'll mostly be around updates around the work that we've been doing related to opioid overdose. And so on the next slide, I did want to start with just contextualizing the work that we're doing. So just reminding the everyone that's involved that the work that we'll be talking about today is going to be focused mostly on the individual and community level. But it's important that we keep in mind the social ecological model of prevention that's used in public health. And so as you can see in the model itself, it has the individual nested within various different influences such as relationships, organizations, communities, policies, and systems. And so the purpose of bringing this up at the beginning is just, again, recognizing that some of the work that we'll be talking about today is limited to some of those individual and community level, but it's important to keep in mind that this is just a portion of the work of the other work that needs to take place across the community to effectively address opioid overdoses overall. And so in the next slide, we'll start with reviewing some of the Centers for Disease Control evidence-based strategies around opioid overdoses specifically. So evidence-based strategies are considered strategies that have rigorous research that's been proven to show them to be effective in impacting the issue at hand, with what we're talking about today being opioid overdoses. And again, this is a compilation of the 10 different strategies that the CDC recommends around opioid overdoses specifically. On the slide, you'll see that there's 3 different stars listed in 2 different colors, the dark blue being next to targeted naloxone distribution and around syringe service programs, also harm reduction programs, and the light blue being naloxone distribution in treatment centers and criminal justice settings. So again, the dark blue being the work that YHD is already doing, and then the light blue, the work that we are going to be implementing here shortly. The other 7 strategies may also be taking place in our community, but in different settings such as medical facilities, jail, and treatment centers as well. So to begin, in that first evidence-based strategy being targeted naloxone distribution, our first update will be related to distributing naloxone to businesses. So on the next slide, you'll see as a reminder that the work that was taking place in terms of distributing naloxone to businesses came about because of many businesses being concerned about overdoses taking place at or around their facility, making sure that they were prepared to address those overdoses, but as well as prepared to keep their staff safe as those overdoses were taking place. To date, we've been able to provide naloxone to 3 different organizations. Again, a local church, a local shelter, and a notary business along First Street. There are several others that are pending our contracting process, but to date, we've been able to reach 3 and actually deliver the Narcan to those 3 organizations. Each organization was considered based on their potential risks around overdoses taking place at or around their facility. And then also, once we determined the risk and saying, yes, it is, you should have naloxone on hand, we provided an orientation, which consisted of providing them the information needed to distribute, to be able to administer naloxone, but then also providing education to all the staff and relevant team members that would need to know how to administer naloxone as well. And at this point, this program is open to all businesses. Previously, we referred to this as a pilot, but at this point, any business that has concerns about overdoses have taken place at or around their business can now reach out to us, and we will walk them through a questionnaire and determine how much naloxone they can have on site for their staff or to respond to overdoses at their place of business. On the next slide. The next update is around the vending machine specifically. So over the last month, we talked to various community partners with varying responses. So at this point in time, the location is still pending. So the actual placement is pending, but we have moved forward with 2 different facilities in terms of the contracting process. So we hope to have an announcement here in the next few days. But just a little bit of background and context in terms of what those discussions look like. Many businesses were open to and supportive of the vending machine itself, but for various technical reasons, sometimes it just didn't work out, or there was some legitimate concerns around the concerns of potentially not having enough staff time to support some of the technical issues that might come up when people are attempting to use the vending machine itself. But in our discussion, we were able to talk to many partners who would consider it in the future, but not necessarily at this point in time. But as I mentioned, hopefully later this week, we'll have an update on the actual placement. And again, that would be one in the Lower Valley and one in the one here in Yakima. And for those organizations that we talked to that were supportive, we are still planning on incorporating them as part of our business, as one of our business partners, where again, they can, even though they don't necessarily have the vending machine on site, they would still have naloxone for their staff or for any overdoses that may happen at their facility as well. So we're still keeping them engaged. And next slide. I would say that the most impact honestly that's been taking place is making sure that we've been able to connect business or organizations to the Washington State distribution program for naloxone. This has been a program that's been in place for quite some time now, at least last year, and there's been very limited engagement. And this program was developed specifically so that the State Department of Health can provide naloxone to what they consider high-risk organizations. High-risk organizations being syringe service programs, street outreach programs, housing and shelter programs, as well as community behavioral health programs. So what happens once an organization is designated as a distribution center, the State Department of Health actually provides them with Narcan, at least 50 kits at a time. And they'll be continuing to provide them until the grant runs out, which at this point, there is no date that's been identified. So this is going to be great in terms of sustainability, making sure that we can get naloxone to the highest risk individuals in our community. And again, is a sustainable option moving forward. So over the last month, we've been able to facilitate a warm handoff for about 14 organizations here locally. And we are working on developing, getting some guidance from the State Department of Health so we can utilize some of our, hopefully we can utilize some of the Narcan that we have on hand to help them distribute while they get signed up with the State Department of Health. So those are details that we're hoping to be able to move forward with, but at this point, again, those are 14 organizations that are pending that participating in that program with the State Department of Health from here on out. And on the next slide, so while we've been talking about distributing targeted Narcan distribution, we know that that in and of itself is not the most effective. It's most effective when you're also combining that with education. And I did want to mention that while we've been working with these different organizations and these different businesses, we have been able to train over 50 community members on how to administer Narcan. And that's important information, as we just discussed previously, that we will be working on a training module that we can have for the community moving forward as well. So that's going to be something that we can roll out in the next few months. But I did want to mention that even with the current distribution of Narcan, we are providing quite a bit of training to community members at this point in time. And on the next slide, a quick overview on some of the communications that have been taking place at the state level. I'm sure many of you have already, whenever you drive down the street, you've seen billboards or on YouTube videos, there's quite big campaigns that are taking place, two of which are sponsored by the State Department of Health and another through the Healthcare Authority. So the State Department of Health campaign has been focusing on getting individuals to order Narcan through their online delivery system. And actually Yakima County residents have ordered 2,400 kits over the last year, which makes us 9th in the state. So there is quite a bit of demand taking place from Yakima specifically. The Healthcare Authority campaign, which is the Friends for Life campaign, is focused more on youth. And that campaign is focused on giving messages on how to help teens avoid opioids like fentanyl, and understanding that fentanyl is very unpredictable, as well as how to spot and respond to an opioid overdose. So those two campaigns are taking place at the state level. And then here locally, we were able to talk to some community members at the overdose awareness event that took place late last month. And we asked community members who requested Narcan what their purpose of requesting the Narcan was and what they wanted community members to know about that, about Narcan in and of itself. So those are the messages that we're sharing here locally as well to complement that. Next slide. And then there was a request to look at youth substance use prevention specifically, and I did want to just reiterate the importance of that. I wanted to share some statistics that we were able to find to again support the need for that increased focus. Again, with young adults being one of the most rapidly increasing overdose mortality rates in comparison to all other age groups, that highlights the need, but then also that 1 in 3 individuals in treatment stated that they first used opioids before the age of 18 and 2 in 3 before the age of 25. So again, I just did want to provide that information to further validate the need and that request in terms of increasing focus on youth substance use prevention in general. And so on the next slide, over the past couple of weeks, we have been able to touch base with some of our local community coalitions. A lot of those conversations have centered around helping with procuring resources on existing communications. And so we do want to revisit the in tandem with our community coalitions, putting together a broader stakeholder group of other organizations that provide services to our youth to make sure that we can look back and see how we can further, again, work within that social ecological model of prevention and not just looking at specific individual communications, but looking at some of the other best practices like the peer-based groups and exploring how we can use some of those evidence-based curriculums for substance use prevention. But again, we'll need to better understand what the current capacity is and what the resources are so we can help facilitate and help support some of the work that's already taking place. So at this point, we have more work to do related to that, but we're looking forward to continuing those conversations and providing updates once we have more concrete information about what the capacity is, and then we can have a better understanding of how to develop a plan moving forward. And on the next slide, I did just want to highlight the fact that there's quite a bit of work taking place at the state level around collating different data sets for opioid overdoses, not just both fatal and non-fatal. And the State Department of Health does have a dashboard available that's quite easy to use, and it can break down the information by county. It's you have a screenshot there on that slide. And we can look again at state level trends and county level trends. And then another initiative that we're working on locally is in tandem with Safe Yakima Valley, working with our relevant first responders to help actually hotspot some of this information. And that would be with this program called ODMAP, which is Overdose Map. And again, just making sure that we can get all the different partners together to, again, use that data and visualize what's going on in our community. Outside of that, we also did get access to state level data through the WEMSIS, which is the Washington Emergency Management Service data that's available. And we were able to do a quick analysis to just a quick update let everyone know that in terms of overdose responses over the last 10 months, the highest rate was experienced in the unincorporated areas of Parker and White Swan. So Parker having 20.4 per 1,000 persons in terms of overdose responses, and then White Swan being at 11 per 1,000. When we look at our incorporated areas, the highest would be Toppenish at 10.4 per 1,000 people and Toppenish at 6.8 per 1,000 persons. So in comparison, I know with Yakima is always top of mind because it is the city with the most populated. Yakima did have a rate of 5.1 per 1,000 persons and Union Gap at 4.1 per 1,000 persons. So there's more to do with that data. We need to make sure that we're able to track it over time and have frequent updates for people to see whether the work that's taking place is moving the needle, so to speak, on these different metrics that we're seeing. But I did want to give a quick update on the local data that we have been able to analyze. And with that, I did just want to conclude with, again, revisiting the social ecological model and showing some of the different initiatives that can take place at those different levels. And again, reemphasizing the need that while we're talking about targeting naloxone distribution and communications, we know that this is just a piece of the bigger puzzle that needs to be addressed across the community overall. And that concludes my presentation.
Thank you. Do we have any questions for Ms. Bravo this morning?
Are you able to go back to the slide with the advertisements real quickly? It's nice to see communication, but I just want to point out that there is nothing there that says, don't actually do this, it will kill you. So I think that we're missing the mark on the message that needs to also be that we shouldn't even be trying to do this because it will absolutely put your life at risk every time. I would love to see us if we need to create it on our own, but the fact that we don't have an ad campaign that says this is so deadly, that we have this spray here that hopefully will bring you back. We've heard from our coroner in the last meeting that it takes 5+ sprays to be able to bring someone back. But I just think we're missing the mark on the fact that we also need to be simultaneously saying, don't even try it because it will kill you.
Yeah, I appreciate Commissioner McKinney's comments. I would also say that I appreciate the focus on the youth and youth prevention. Obviously there's the need for interventions. There's a value to that, but we keep we keep our kids and adults from trying in the first place. We were just so much farther ahead. So appreciate that effort and looking forward to hearing more of that as you're planning.
Yes.
Thank you. Anyone else?
Just a quick comment. I was listening to some investigative reporter who was talking about the fentanyl crisis and how this, one of the things that helped it emerge is actually the OxyContin problem. As things began to be ratcheting down, people were addicted to OxyContin, and then they turned to street drugs. And the street drugs happen to have fentanyl in it. So a lot of this actually goes back to the 90s when the OxyContin prescription rates went sky high, under the premise that it wasn't addictive. But it certainly is.
Which also was a product of CDC recommendations, the World Health Organization. So those were all the contributing agencies that were telling the public and the doctors who prescribed the medication that it was perfectly fine and safe and non-addictive.
It was Purdue.
I'm just saying the medical community, the public health community as a whole said nothing to see here. This is totally fine. And here we are.
Actually, it's not quite that. They missed the mark. I
I-
didn't predict the outbreak because the background information suggested it wasn't addictive, but they got caught with their, you know what, down.
Well, so did our community.
Any other questions or comments?
Commissioner.
Can you hear me okay?
Yes, go ahead, please.
Hey, since we were looking at kind of the ads on the Stop Overdose Law, I know one of the things that I've noticed when you actually visit the website, it's supposed to show you where Narcan is available in your community. But for whatever reason, it only shows that in Yakima County, there is one place in order to get Narcan, and that's the White Swan Community Coalition. So I think for what it's worth, you know, the state has put a lot of money in putting these billboards around our county. It would be nice if we could figure out whom we need to contact to get that Find Narcan track finder updated so we can share where all of these resources are in our county. So that's all I wanted to add.
Thank you.
And I would add that there is state-approved evidence-based campaigns that the coalitions in this county already use and the state uses that are about healthy choices, making healthy choices, encouraging parents to be involved. So there is those campaigns. I would also encourage using some of those.
Thank you.
I think is that a recommendation? I think it's an ask, Lillian, is what we're asking for, to see just as much coming from the health district about not even trying at prevention as often as we see.
Yeah, that may be part of the comments that were made in terms of supporting some of the existing communication campaigns. So I think that's likely in line with the comment that I made previously with the community coalitions wanting support. There's more resources on things that have already been developed. So if those are, that's like, yes, so yes, we can move forward with that.
And we can elevate those too. Those are not new, but you're right, that can be made much more.
I just think it should be equal to equal, as much as we're talking about Narcan being able to save a life, preventing the use of it itself is just as important.
And to your point, and that's the spirit of the purpose of bringing up the model in the first place, is absolutely, we can't just focus on one aspect of it. It's a whole sphere of issues that we need to address simultaneously. So I agree.
I just simply want to enforce that point. I think we're just making, sometimes it feels like we can make an assumption that everybody's going to use it or a lot of people are using it. Nothing we can do. There are things we can do, and we should use all those avenues to keep people away from it in the first place as well.
And to respond to Commissioner Curtis's comment about places where it's available, certainly it's available at pharmacies, and if you have the privilege of having insurance, it can be covered. It can also be bought over the counter, but again, the cost can be prohibitive for people who don't have means. So that's one of the reasons that we purchased the Narcan that we did, because there are many people who are looking for it, interested in it, but there are barriers financially, there's barriers to health literacy, and also, frankly, there's barriers because people can often feel shame or embarrassment to be asking. So it's not an easy process. We're trying to overcome those barriers.
Anyone else?
Mention one more barrier.
I'm
And
sorry,
I
ma'am.
mentioned there is one more barrier. They are scared because people are scared to be coming to healthcare provider and then being sent to the jail. That's also something that we need to consider.
Thank you. So all conversation now belongs to the board. Thank you very much. Anyone else on the board? All right, then we will move forward to staff reports, agency reports, starting with our executive director.
Yes, thank you. Good morning to the board and to the members of the Washington and to our guests. I just wanted to share briefly because we've already had an executive session and we will have some robust discussions about our budget. Just touch on a few things. First of all, we will have a discussion on our budget. Chase has been working very hard and the team has, myself in mind. It's a strong budget. Financially, we're well prepared. We've been fortunate to have additional funding streams that has allowed us to hire new staff, which has been wonderful, but also prepare for events that have been quite varied over the last year, and we anticipate that to happen in our county. We are facing many different issues, and part of our goal, as we've talked about as a board, is being a responsive, community engaged health district. And so community response has really been at the heart of what we're doing. We're dealing with things around PFAS, guava. These are all water issues. We've had 2 fires, which are complicated and normally don't happen at solid waste facilities, certainly not back to back. We are dealing with a really complicated issue around opioids in our community and fentanyl specifically. So I did want to share with you and compliment the team. You're looking at the principals who have been working on this issue around the lock zone. Melissa, Lillian, Chase, Brian, but also we have many team members who have been working on this really tirelessly. Building and rapidly building these kinds of initiatives and then rolling it out with partners, with the support of community members, engaging our partners to find out what their barriers are, is really at the heart of what we've been doing when we talk about being a community response agency, and also talking about our concept of really being a catalyst for this change. It's not about the health district being in charge whatsoever. It's about helping to, as Lillian talked about, having multiple inputs in the community so that we can address a really longstanding issue that's very, very complicated. Again, our goal is to avoid people dying. Our goal is to avoid children becoming addicted to drugs in the first place. And certainly recognizing that there are many barriers to people being able to live their best life in a really vibrant and wonderful community. So that's our goal. And I share that with you earnestly because it's a great deal of work behind the scenes to do these things rapidly. And so my hat's off to the team. That's all I wanted to share unless you have questions, because we really will be having a lot of discussion around issues that relate to our budget and also certainly environmental health issues. So happy to answer any questions if you have any.
Any questions for the board? Thank you. We will move on to our operating officer.
Yep, later in the meeting today, under unfinished business, we will be having a public fee hearing and also up to vote to the adoption of our 2024 fee hearing. We'll also be going through the same process next month with our budget. Chase later will be introducing the budget, and we will be advertising in the newspaper and on our website and in the front lobby our budget, and also be advertising the public hearing for the budget that we'll have next month. And then that public hearing, then they'll be up for a vote to approve our budget. And if for some reason that doesn't pass in October, we do have another meeting in beginning of December that we can also vote on.
Thank you, Bishop. I can make questions. And we will move on. Next is our financial report from Mr. Porter.
All right, good morning, everybody. I got a couple of housekeeping items before we move into the main event, the 2024 budget. The beginning of the month, which almost seems like years ago now or months ago, we had an audit exit interview. Representative Byers and Commissioner Lindy was there for that exit interview between auditor's office, and it went very well. All we had was minor recommendations, and with an audit, that's just about as best as you can hope for. Auditors are paid very well, and so they have to find something, right? So we're never going to get out of a audit without any recommendation. At least I'd like to think so, right? Any questions or comments about the audit? Okay, moving into the financials. We'll do the financials first, go through them quickly, and then we'll start in on the budget. We had about $164,000 gain for the month of August, bringing our total excess revenue to 1.7 million. Our allocated budget for the month was, for revenue, it was 6.6 million, and actuals coming in closer to 8 million. For expenditures, it was 6.6 million budgeted, and we're coming in closer to 6.3 million. Any questions on the summary page? Okay, moving into the income statement, a lot of the same trends that we're seeing this month, we've seen throughout the year. A lot of foundational public health is the main revenue for us. And also what we're seeing is a large increase in our developmental disabilities program. We had extra funding from the state come in to help support providers here in Yakima. That is mostly pass through funding, as well as an investment income. That's really that $700,000 is very surprising to see it that high. Moving into expenses, not a whole lot to note for the month of October, business as usual. Last month, Commissioner Curtis had a question about the overages for contracted services. I did look into that, and that was, as I was thinking last month was Culligan Services, the water delivery in the Lower Valley. That's for that service, it's been on 37,000 that has been spent for that this year, which is right along with our overage for that line item there.
That's big one.
Yeah,
It's a pilot project.
yeah.
I just mentioned Guam, I just got them together.
It's Guama. It is
It's
definitely
Guama.
groundwater management area investments. Yes.
Yeah.
It's a lot of water, but
Yeah.
it's a lot of water.
It is true. It is a lot of water. That is true. Any questions about that part? Moving into the last page of the income statement. We did not a lot to note here. The overage for repair and maintenance was a lot of our building updates. We have a lot of painting inside and outside is the main reason for that overage. Any questions on the income statement? Okay, moving into the programs. I don't have any comments necessarily for this unless there's any questions. The majority of our programs, as you can see, a big chunk here of the clay colored shade is our FPHS programs. And we'll get a little bit more into FPHS for our budget. It really is going to be a main driver in the years to come. Any questions? Next page. Not much to note here, other than our developmental disability program is beginning to expand. We're starting to see more light items for the DD program, which is welcome. It's a much needed service here in Yakima. Question. All right. COVID reporting. Still not much to report here. It's ratcheted down quite a bit. We are expecting some advertising expenses to start coming through for that. These next couple of months, we're seeing an uptick in numbers, and so there's going to be a slight increase for messaging in the community. Question? Last but not least is our cash flow. We had an increase in cash by $100 million, which is right along with our FPHS funding. We received that funding in August. And that, as we expected, has an uptick in our cash reserves, and that will start to dip down throughout the rest of the year. As that FPH money is all front loaded, we receive the amount front. A lot of our funding is reimbursable. We incur the expense, we have the expenses, and then we invoice DOH for those, and then we get paid back. FPHS is funding all up front, and then we spend that down throughout the year. Okay, so that wraps up the financials. If there's any questions? Okay,
I got one.
Oh,
One quick question. Chase, I remember like at the beginning of the year, we had some money, quite substantial amount of money from like, I think the Public Health Foundation or what have you, that we needed to spend by like June or whatnot. Do we still have that money, or did we have to return that, or how did we?
No, yeah, we were able to get that spent up more or less. We were underspent in that by like $1,600, which is actually really good, really well. And a lot of that money, as you can see, is the technology, the painting that we have here. And so reaching out to DOH and let us know that we were underspent by, and that's really the goal, right? Is to hit zero, like Price is Right, not go over, right? We want to, not go over. And so, we came really close to that number and then talking to DOH and they consider that de minimis. So there was no payback needed at all for that.
Right on. Thank you.
And Commissioner Curtis, that was the Foundational Public Health Services funds. that we
Yes.
were-
Yes, sir.
Thank you.
Okay, the 2024 budget, as Ryan said, that today would be the presentation of that. And it's not, we're not voting on that, or you're not voting on that today. That'll be next month. And so if there's any questions, today or later down the road, please just let me know and we can have those answers prepared for you if you have any, on the 25th of October. Okay, so moving into our FTEs, last year, for this year, 2023, we had budgeted 49 FTEs. And we had 49 with that number in mind. Once you hit FTEs, there's additional taxes kick in, paid FML, as well as additional demographic reporting. We're seeing a need to go over that 50 FTE mark, and we're ready for that. We have some very good payroll accounting technicians to help us through that adjustment that we go through with that, and so we're prepared. So we have 53 full-time equivalents that we have here. The new FTEs are marked with new. So if you would like to see which ones we're planning on pulling in for 2024. And really, a lot of it is reinforcing our internal infrastructure. It's managers, coordinators. Is there questions about the FTEs?
I see the new ones. Is there anybody lost?
No. No, we certainly, when we're bringing on people, our idea is to keep them on long term. We're not really trying to have somebody here for a year and a half. As government funding knows, sometimes that does happen. However, we're always trying to look to the future, trying to say, okay, if we're going to pull on a new FTE, is this going to be sustainable 5-10 years out from now? So we don't look at adding FTEs very lightly. Questions?
The policy assurance coordinator, what does that individual do?
As we're seeing that we're moving into this new year, with COVID, we're having some gaps. What we have here, this person would be almost in a way like an internal auditor. They would be looking at programs and making sure that programs are running, the deliverables that are for the programs are being met, reviewing policy and making sure that we're operating within our policies. That's really the main issue that we get caught up with state auditors. You have this policy, are you operating inside the policy? So that's what that person would be, making sure that we're operating inside the policy, making sure that our programs are meeting their deliverables, and adding new policies as we see needed.
Yeah, so this, Chase addressed a lot of the assurance part of it in the policy right now. I'm writing a lot of the policies. We have our directors writing a lot of policies. So then this person would be able to do that as we continue to grow. We have a lot more policies that actually need to be in writing. And so instead of having the directors writing that policy, we'll have a position that would actually be doing that.
And if I may, one of the issues that we're finding is that, again, public health, like many agencies, had become really routine in terms of funding and programs. And as again, we've become a community response agency and are working very closely with our partners statewide. We have quick initiatives that we're trying to respond to that also sometimes comes with funding, but this becomes legal. And our goal is to work within the law at all times. So the more we are responsive and the more we have infusions of money through different programs or emergencies, the more we have to be quite serious about making sure that it fits within policies, fits within procedures. Certainly, we have to be concerned about audits and so forth. And it's just we've had a dramatic change to our funding streams during COVID. And I think that this is reflective of us being protective and smart with our funding and certainly with our projects in the future.
Yeah, unlike private businesses, a lot of private business, small business, even corporations, you can have handshake agreements. You're going to do this for me and I'm going to pay you for that. That's not necessarily the case in government. There needs to be contracts and assurances. You're going to do this work and this is how much you're going to get paid before you do the work. So we're always having to write policies and those types of things around that. And it can get a little complicated when you want like a handyman to come in and fix something. Do you need a policy for that? You need a contract. You've got to check the department for them, all those kind of things. And this is what this person would help us with that. Yes.
Yeah, it just sounds somewhat akin to a compliance officer.
Yeah.
It is that- So something as simple as wanting to purchase naloxone for distribution to give to the community to save lives becomes really the handoff. It becomes, it's a medical responsibility. There's procedures, there's contracts, working with James to ensure the integrity of the process legally. It's quite complicated, and so we feel very strongly that our goal is to always be above board in everything we do, but to also be prepared for the unknown. And that's what we're trying to do. It feels governmental, it feels very bureaucratic, but it's actually to ensure the integrity of the process.
I just would be remiss if I didn't say that if you think government isn't growing, this is evidence of it. I think our entire government in the US is just absolutely bonkers. And our debts are increasing per capita. And certainly there's good work to be done, but we're talking about a program analyst who's supposed to compare policies, and the more policies and laws that get written, the more people we have to compare them all. And this is exactly why government is so costly and so large and continues to grow exponentially.
Any other questions or comments from Mr. Porter at this point? Go ahead.
Okay, thank you. Moving into the next page, and this is where we start to get into the figures around the programs. This would be the summary page. There's a lot more programs behind these individual summaries. I'm going to speak to the summary page. We'll go through, we'll review the detail, but I really won't speak to the detail. As I was mentioning earlier, a lot of our indirect programs, and our indirect programs are mainly administration. Direct programs are when I'm spending time in this particular program, SNAP-Ed, I can charge that directly to that, or BCHP, I'm working directly with BCHP, I can charge that directly to BCHP. Administration costs, when we're doing payroll, when we're doing accounts payable, that's everybody. And so that would be kind of these administration. And we're seeing a tick from a lot of our administration activities into direct programs through our foundational public health services. It's such a large scope with that. And we're receiving additional money for that. So last year we had about 2.5 million for that. This year we're gonna have close to 3.9 million of that, which is $1.3 million increase. And as you can see on the very far right, that's a change in FTEs. Our change in FTEs are going up in that program by almost 7 FTEs. A lot of our other FTEs are getting dropped, and they're going into that particular program. We do have a new line item this year for capital expenditures. We'll get to that a little bit further in the presentation. Our strategic planning and partnerships, there is a slight decrease in FTEs, but we have some additional contracts within the community that we're looking at applying for the next year. The largest decrease we see on here is for a COVID-19 response. And I think that's a welcome sight for the majority of us here. That's definitely or all of us. It's good to see that our community is more healthy than it was a few years ago. We're having a large increase for the breast cervical health program, the BCHP. We have become a regional provider. We are handling the BCHP program for more or less Eastern Washington. And so we're happy to see that as well. Moving into environmental health. One thing that we have a new FTE for an EH, and that'll help increase turnaround times, food inspections, and just overall inspections in the community. We're seeing that we're going to really put more effort and time into the food program, and that's the largest increase. And then as well, moving on down the line to developmental disabilities, we're having larger increases from that from DSHS, and the majority of that is flow through into direct providers.
Maybe you can tell me, you talked about the increase in the food program by demand, having a significant increase in the community of opening of new restaurants.
Yeah, it seems to be that way. Yes, we're actually seeing a trend increase in those licenses pulled. So yes, I can't necessarily speak to how much or where. I think a lot of it has to do with the pandemic. In 2020, a lot of places closed. And we actually, for a long time during 2020, didn't enforce license fees. It was so chaotic that we, don't know if people were open, don't know if they were closed. We didn't want to put any extra burden on the community. And so we're starting to see, as that gains traction, that's starting to pick up. And it's almost all across the board in EH. There's more building There's actually a lot more attention to water and PFAS. So EH is certainly, fires, so EH has certainly had an increased activity.
And I think, Sean, you can speak now or to your report about the dramatic increase in food sales. We're really hovering around the 1,100, 1,200.
Yeah, just to give some perspective, we are, within 100 or so food establishments of Benton Franklin counties, the Tri-Cities. The Benton Franklin Health District has 10 environmental health specialists to their food program alone. So, we work really hard to be very efficient and be very effective with our time. But the food program is growing. We're seeing a lot more brick and mortar establishments being licensed. We're seeing more mobile trucks. And certainly this summer is by far the busiest summer we've had in a number of years for temporary food events. And I have staff, putting in 15 to 18 hours a weekend doing temporary food inspections, which is absolutely necessary and needed. But yeah, we're starting to see our inspections per month go up. That's additional workload on each individual staff member. In addition, takes away from other programs that they have responsibilities. So we definitely see the need to add another inspector to the staff to keep our turnaround times during a busy season of development to a minimum and be able to accomplish our food inspections over our non-busy land development season as much as possible to free up time in the summer.
And Jackie, in her previous role, did work on a lot of work around federal standards that other jurisdictions in other parts of the country have been working on. We received grants for that. So again, increased efficiency and effectiveness has been tied to being able to keep pace with the need for more inspection.
So I have a question, and it's kind of keeping in the last comment. We've got tobacco prevention, we've got marijuana prevention. They have their own line item. We're spending $63,000 on needle exchange. Where's the fentanyl prevention line item?
Well, we pay for a lot of that with our Foundation of Public Health Services dollars. So the additional money is actually not tied to a specific grant. It's tied to a larger investment that the state is making.
So how are we to know what the investment is?
Yeah, so with the fentanyl, there's quite a few different programs, because there's the messaging side, which would be supported by FPHS funding, which in the details on the next page would be 135 communication. We're also using what we call the life course. That's kind of new funding for Yakima Health District, new funding for other health institutions across the state. Those access linkage to health services, disease, injury, violence, and illicit substance use and overdose. Those are our main items that's being paid out of. It'd be FPHS funding is the majority of the funding for those things. So it's different individual line items, but still one pot of money that's coming out of.
I think that I would prefer that we at least see if there's a way, at least internally, then if you want to provide a living document. But I think, again, given the situation in the community, I think it would be important for us to be able to contrast how much money are we spending on opioid and fentanyl prevention. If we have a line item for something like tobacco use, it seems like the public would want to know what that amount is. So I'd like to see that.
So we can certainly do that.
Yeah, and right now, that would be in the next page on page 3. That would be 806. There's Foundational Public Health Services. The very last one, life course illicit substance use and overdose. That is for 2024. That would be our majority right now. Of course, that can change. We are striving to be a nimble organization as the board, as the community needs us to shift direction. And that's why we have Foundational Public Health Services. It's really been written so that as the demand changes, as the direction changes, we can change with that and not have to wait for the funding to come to make that change.
But I see it says substance use and overdose, so that's not specifically prevention. So I just want to make sure that we're clear. We want to see how much we're spending on prevention.
Prevention alone.
Oh, prevention only, not just the.
Correct. I would like to see, I think the public would like to know how much are we actually spending on prevention, similar to how we spend to prevent tobacco use.
Yeah, that's something we can do.
That's something that would actually fall under 805 case that we've been billing our time to for prevention.
Yes, sir.
Thank you.
Thank you, Commissioner McKinney, for pointing that out. Appreciate it. And I also just want to comment on the increased amount of work being done to permit food services, which speaks very well of the growth in Yakima of that particular industry, recovering from COVID and also just community use in terms of 5 million food trucks. I love it. Everywhere I go, there's one available.
And they're all really yummy.
They are.
They are.
I tried many of them.
We're very fortunate. And that's another thing I did want to share. We, the fee hearing is important, where our goal is not to raise fees if we can do everything to avoid it. And so the additional funding streams allow us flexibility that reduces the need to actually increase fees to the public.
Yeah, we are. I've heard the lowest in the nation. We're definitely lowest in Washington State, which can make us lowest in the nation. I'm not sure about the nation.
I believe our temporary food event permits are the lowest in the nation.
Which is, considering how many we have, is very interesting, which also speaks to the efficiency of the staff. Because, we're smaller than Benton County, aren't we, in terms of population and other things, and yet we are almost equal to them in terms of our permitting.
Yeah, as you all know, everything has increased in price. Every cost has increased. I don't know which hasn't, except for our fee.
And if I may, when Sean talked about Benton Franklin having 10 food environmental health specialists, he's talking about the food program. We have committed for many years now to being cross-trained in our environmental health program, which means that our staff are trained in all our programs, which allows us to shift priorities when the need arises in our community. So whether that's seasonal or it has to do with the change in, as we've talked about, the number of permits we receive, we can flex to do that. And that's really wonderful. It allows a work-life balance for our staff, which means that people can take time for vacation, or if they have family responsibilities, the work continues because it's not their work alone. But it's also allowed us to be really quite efficient. And my hat's off to Ryan and to Sean on this issue, because it had to do with a lot of negotiations with the unions, but also a commitment to training, which is very important.
Okay,
Really
So
quick,
there's-
line item 613, I think it says like child death review. That's a new program for us. And what does that entail?
actually, no, it's
Not a
not.
new program, and I will have an update on that in my report.
Right on. Thank you.
Yeah, Commissioner Curtis, we actually have child death review in a couple different spots. We have the 613 under FPHS, but we also have 612 under communicable health diseases. So we have a couple different funding pieces for that, that Melissa will speak to the operations of that program. Is there any other, again, I wasn't necessarily going to speak directly to any individual programs on pages 3 through 5, unless there's any questions on them. Okay, and again, you have a month to chew on this, so you don't have to have necessarily anything today, but if you do have any questions about anything, please let me know. And I will certainly have a answer for you for the next Board of Health.
Just a clarification, so you're saying, so you're focusing on that we don't have any increase in fees and we're one of the lowest. But that's because we're getting outside revenue, we're getting money from the government to help defray that.
Well, we're not receiving money specifically for fees. What we're receiving is money through Foundational Public Health Services, which is money directly from the state legislature. It's an investment in reality to the fact that the state had not invested in public health for decades. But also we negotiated with the state and with our partners. It's the local health jurisdictions like us, the State Board of Health, tribes, and the State Department of Health collectively working together. The goal is to have investments that can be made at a local level that we deem at a health jurisdiction level priorities. So as an example, when we've been responding to these fires, that's been state funding that's allowed us to pay for staff time to do that. It's not based on fee generation. And so we're not passing that cost on to taxpayers. We are using taxpayer dollars, but we're not asking for additional fees from small businesses.
Mm-hmm. I'm just wondering what, there could be an analysis in how much we pay in taxes and the increase in taxes. Is it really better for the community and the people to pay lower fees but higher taxes? And are we actually taking more out of our hard-earned money pockets to pay taxes where we could just pay a little more in fees and we'd be better off?
Well, one of the things that I'm pleased about is that the funding that we're receiving is specific for Yakima County. So we're not responsible for the cost of the taxes, but the goal of having investments that come directly to Yakima County to improve Yakima County or protect Yakima County is important.
If we were to say reject this FPH funding and said, no, we don't want it, and we send it back, that would not lower anybody's taxes. And so we're able to use this funding to help make sure that there is no increased fees for our community.
Said differently, this is the decision of the majority state legislative body, and it is a new program that they have propped up and funded using the taxpayers' dollars of Washington State.
Any other questions or comments?
Okay, moving on into the next part is our income statement. As you can see, the big winner here is Foundational Public Health Services with a large increase. $1 million. Our federal funding is decreasing. A lot of that has to do with COVID starting to fade into the background. I'm expecting increased funding for BCHP, water and solid waste, as well as development and disability increase in the DFHS revenue. Moving down into the expense sections, we are seeing a main increase for salaries and wages. Our janitorial services is having a large uptick. We're also seeing increased wages for contracted services where our Culligan water is coming out. That's where the line item, we have that budgeted this year for that. We have two types of, or two buckets, if you want to say. We have our operations and we have our enhanced program. I'm going to speak to operations right now, and then I'll talk about enhanced after we review the operations piece. Next page. Looking at the last end of that, we're seeing an increase for maintenance costs, and we're also budgeting some small tool replacement. We have some additional funding for our BEEPR, our public health emergency response, and so Andy will probably get some new toys. I'm sure he's excited for those. The one new thing that we have here is for capital expenditures. We're seeing a need. We were talking earlier this year about purchasing another building. That didn't quite work out. And so we're budgeting this year. We have operational and enhanced funding budgeting this year for two things, updating this building. There's certainly a workflow that we're seeing that could be better, could be updated. And that's a large part of that chunk. Also, we're having, with the new increased staff, a larger demand for our vehicles. Oftentimes, all of our vehicles are checked out and staff is having to start to use their own personal cars. So we could be looking to purchase another vehicle or two for 2024. So bridging into the enhanced program. So our operational expenditures is at 11.4, close to $11.5 million. And our enhanced is a mechanism to start to draw down any reserve funding that we have. Year over year, we budget approximately $500,000 for that. This year, we budgeted $1 million, a full $1 million for that. The majority of that expenditure is for the building. Is updates for the building. A large part of that too is for any contracts within the county to help utilize any growth with public health in mind.
Just want to point out the 72.6% increase in fuel.
Definitely.
We're in a big county, right? I mean, it's, yeah.
No, it's simply the cost.
Yeah, no, it's.
Yes.
But don't worry, nothing's gone up, guys, nothing to see here.
As we all go to the gas station and say that, yeah.
Keep your eyes.
Our EH staff can easily put over 100 miles a day in their travels doing this.
Wow.
Yeah, drive to
100 miles.
Grandview.
Can we line item the cap and trade portion of that?
Just call it Bidenomics.
Sign the initiatives.
Yes.
So that, unless there's any additional questions, that wraps up my presentation of the 2024 budget.
As you're talking about vehicles and the potential option of purchasing more. Have you looked at the idea of maybe instead of purchasing more vehicles, looking at simple mileage reimbursement, using the personal vehicle?
We
That would
do,
pencil
we
out.
do have, yes, absolutely. When people do use their personal vehicles, well, there is a mileage reimbursement. They submit their mileage and that goes through the proper channels. The catch with that is insurance. If somebody goes out and they get in an accident on company time, our insurance does not cover them. So our employees have that additional risk. If they're an offender bender, if they're in a serious accident, our insurance will not cover that at all. While if they're in a YHD vehicle, that all of that liability will fall on the health district.
Sure. And Commissioner Lindy, I'd also mention, given the varied work we do, having all-wheel drive vehicles, certainly going over the pass during inclement weather is important. But also venturing to the lower valley, we have many people who are off-roading to go to sites that are being developed. So it's muddy, it's craggy, and a lot of people wouldn't want to do that in their own vehicle.
Yeah, yeah.
Any other questions or comments? Thank you, Mr. Porter.
Thank you.
Move on. Next is our. Officer, Dr. Martin.
Morning. Going in 30 years.
Congratulations.
Never been a meeting where I haven't had something that came important, which stuck out. And this meeting's no different. So I'm going to give a kind of broad stroke update on COVID, which we're going to talk about in detail. Then I'm going to speak to the vaccine update, what the new vaccine is all about and what it's going to do. There's another section where I'm going to just discuss what the current mask recommendations are and how it impacts people. And then a few words about long COVID. And at the end, which the early discussions, I'd like to actually dovetail a little bit of history about fentanyl into the discussion of what's going on. It's much more insidious than you think. So COVID update, there has definitely been a new surge. So the estimate based on wastewater measurement of virus titer, they're thinking about 600,000 new infections per day. And because of the big increase in those cases, there's more hospitalizations and there's an increase in death, but nowhere near what it was with earlier strains. So some areas of the country are already reporting decreased titers of virus in wastewater. So it might be near the peak of this. The activity nationwide is pretty much distributed equally in contrast to Alpha and Delta. Alpha seemed to be concentrated in the Northeast, particularly New York, and Delta was concentrated more in the South. There's no explanation for that. It's just a little bit different. And these are all Omicron derivatives. All the new strains that are coming out are all from that Omicron, which is the highly transmissible. And it appears to be less and less virulent. So even though lots of people are getting it, the proportion of people that end up in the hospital or dying are less, although the total numbers are greater because the total number of cases are greater. The vaccine has definitely had a contribution to this. There's no question about it. And the use of drugs early in the case in the progression of disease in the first 5 days, like Paxlovid and remdesivir, also changed the outcomes a bit.
Oh, I'm sorry, has prior infection also contributed?
Everything does.
Yes,
Everything does. That's actually a major contributor because so many people got Omicron in the last 2 years. The section of the population that has some immunity is greatly increased from it. For those that haven't had it, the vaccine is still good. For those who've had old Omicron or older strains, the vaccine is still good. And I'll talk about that in a second. The strains seem to be gaining ability to become contagious. Yet, we're in better shape than we were. That doesn't mean that a new strain won't cause a problem. We just have to take them each one at a time as they come. So as far as what's going on locally, so we'll update you. The new vaccine, it's not a booster. It's not one of the previous vaccines that have been used. The last booster we had was called a bivalent. This is not a bivalent. It's covering, it is fortunately though, capable of covering the strains that are now causing concern. So it's available in many places. I think we check Walgreens and Safeway?
Yes.
Have it here, okay.
Good.
If you want it, you can get it if you're greater than 6 months old, all the way up to, ready to check out. Whether it's available the day you go in or not, it is effective. Childhood prevention seems to be important in the spread of the disease. So if you want your kids to get vaccinated, it's safe, they can go get it. Interesting survey was done by Reuters, the news agency. So they asked people about what their interest is in the vaccine. So about 30% of people that they asked very interested, meaning they'll probably get it. 24% of the people they asked said they're somewhat interested and they were thinking about whether to get it. Not 70% of the people were not, 17% rather, were not interested at all. Of the people that were not interested, about a third still thought the vaccine was dangerous. And no vaccine, no medication is perfect. There's going to be outcomes that are undesirable. But this overall is a very safe vaccine. 5% of the people that weren't interested were not interested because they didn't think COVID made you sick. So still a lot of different opinions floating around. The vaccine that's currently out now is the only vaccine that's available. The old vaccines have been removed because they're not effective against the newest strains. So if you get this, you can, the best time to get it is between now and say end of October or the winter season issues. They don't at this point recommend a second dose for it because so many people either had previous priming from infection or previous priming from vaccine or both. So one shot and maybe next year we'll have another formulation available. Just make it, 6-month clip at a time.
Data on, just offhand, how many people were involved in the testing before they made this one go live?
I don't have any data, but it's probably in the thousands, if not 10,000s. The general theme for these whole vaccines was to test large numbers of the population. In fact, the original vaccines have been tested on a larger population than any previous vaccine.
I had not heard that they tested on thousands of people, so I really like it if you could email us all that study.
Well, I'm just taking a guess. I don't have any papers that tell us.
Oh, okay. Well, if we're recommending 6-month cure, babies go get this. I'd really like to see the study that shows that it was tested on infants.
Yeah, remember that the vetting of this goes through CDC, NIH, and the ACIP, the American College of Immunization Practices. So you have dozens and dozens of people looking at the data and making it. So I don't have it in hand, but
Oh, no,
it's
I would love to see the study, and I'm sure if you could share it with the whole board, it'd be good to have that.
I know probably more than one study, probably multiple areas. So vaccine remains the very best defense against getting severe illness and hospitalization. We move on now to the mask recommendations. Are there no questions about COVID or vaccine?
Dr. Barr, just one question. Has you been specific looking into myocarditis associated with the new vaccine as compared to the older vaccines?
Yeah, there doesn't seem to be any increase in the incidence of myocarditis for the subsequent strains. And it seemed like the first ones that came out might have had a higher incidence than the subsequent. It's not going to be zero, there's always going to be a list of side effects. But it does seem to be as safe as the bivalent boosters have been.
Real quick, could you happen to know off the top of your head what the hospitalization data is for anyone under the age of 18?
Yeah, it's a couple years ago, I actually tried to get that pulled up pediatrics and I couldn't get an answer.
Well, in the state of Washington, they won't post anything over 35 because there's not enough data. I think, Melissa, we've talked about this, where if there's not enough, it would be a potential violation of HIPAA law, but they haven't reported anything.
Like I said, I tried to get it. They wouldn't tell me. So,
That's interesting.
yeah. Well, that was before multi-care was in place. Maybe different now. The number of people that are here locally, I don't have an exact count, but it's not that high. They're not. Plus, there's a really nice thing. It would segue into my next talk. I heard yesterday they have 500,000 masks available, and the health district has a whole bunch more. So mask shortage isn't going to be an issue now. Good thing. So segueing in there, the recommendations for mask wearing are recommendations, which is different. It's not mandated, it's not required, the recommendations, and a lot of the recommendations are common sense. So it's not so laborious to deal with things. So according to the state's recommendations, they have, which is on their website, I'm just reading right from their website. When indoors or in public transportation settings, so basically when the ventilation is poor and the density of people is high. Again, it's a recommendation. Indoors is somewhat contingent on the rate of hospital admission in the community. So let's say we had 50 or 60 people in the hospital with COVID, that'd be a fairly high rate of hospitalization versus say 6. So if that rate goes up, we can actually find out, we can make some nice recommendations about what that is. So right now, I think it's probably not crucial as we're not wearing masks in our indoor situation in a room with good ventilation. If you're in a healthcare setting, whether it be a nursing home or a hospital, possibly even a daycare center, and the activity in the community is fairly high, there's another recommendation of wearing a mask if the people you're going to be visiting or exposed to are at high risk of getting a serious infection. So that could be a nursing home resident who's maybe 78 or 80. It could be somebody in a hospital that's getting chemotherapy for their underlying malignancy. So in hospital settings and stuff, there's so many people that are high risk. It's probably a good idea if you were a healthcare provider to wear a mask. Also, some people actually like to wear a mask. I mean, they want to wear a mask. And in that setting, if I was going to see a patient that was wearing a mask, even though they might not be high risk, I'd respect that and I'd wear a mask myself. And I think a lot of other healthcare providers feel the same way. And then the last thing about the mask is if you happen to have symptoms of COVID or a positive test, the recommendations haven't changed much. Like if you have a positive test, stay home for 5 days until you're feeling better. If you test positive at the end of that 5 days, you might need to hang around a little bit longer. If you test negative, you still want to wear a mask if you go out in public for another 5 days, a 10-day mask protocol. The repeat testing isn't perfect because both tests, the PCR and the rapid test, can stay positive longer than you're infectious, but there's no easy way to determine exactly when your infectivity goes down because it takes a virus count. And the thing is even more difficult to get a virus count. We don't actually know what the minimum amount of viruses that we would secrete that actually causes infection. So when you're actively infected sick, there's a lot of virus. So much easier to deal with the current recommendations. Remember, they get close to being required in healthcare settings, but it's still recommendations. And I think these, with masks available now, the supply we have, and these pretty clear indications, it's going to be a lot less of an issue to deal with the mask problems at this point. Of course, we want everybody vaccinated, the combinations, the type of mask you wear, as we talked about in the past, just have a lot to do with how effective they are. And the other thing that's really difficult to control for is how well the masks are being used. If there's half the people wearing them where all the people should wear it, but not if they were not wearing them the correct way, if they're wearing them with their nose, all that confounds looking at specific settings and saying the mask was useful or wearing a mask wasn't useful. You have to have all things being equal to determine whether a specific setting will show you what the mask work and the mask don't work. So a lot of studies suffer problems because of that inability to really nail the mask usage. KN95s for the general population, they're available and they're the best to wear if you're going into a high density situation where there's people and the community rates are high. They're great. In the hospital, they use N95s, but they're fit tested. So they make sure they really do a good job. Obviously, out in the community, we can't fit test everybody. The surgical masks, single mask, double masks, they're not as good, but they still work. The cloth masks are not as good, but they still work a little bit. And then, of course, no mask doesn't do anything. Okay. So a few words on long COVID. They're starting to do some studies And it's looking like there are immune responses that are measurable in patients who have long COVID versus patients who don't have long COVID or never had COVID. So with these identifiable lab tests, they may be able to have a more definitive diagnosis and hopefully lead to some definitive therapy. It seems to be a dysregulation of the immune response. So there's excessive responses to some challenges and inadequate responses to other challenges. So we'll see in the next year, there might be some recommendations about specific tests to help diagnose it, which now it's just syndromic. You know, patient complains of XYZ, and then you say, okay, it sounds like they had COVID, and they had COVID in the past. So
Are they distinguishing between those who got the shot and didn't get the shot as far as
vaccine,
long COVID goes?
you mean the vaccine?
Shot, yeah.
I mean, there's other shots you can get, but you mean the
The
vaccine?
COVID shot, yeah.
So the vaccine decreases the incidence of long COVID. Long COVID seems to be related to the severity of the COVID, so people who get vaccinated are going to have less severe. But previous COVID and the vaccine don't prevent it completely. It seems to be related to the severity of the disease, so people who have severe COVID will have more likely chance of getting long COVID as opposed to mild disease. And having had COVID before doesn't protect you from getting long COVID if you have another episode of COVID. So, you know, anything you can do to decrease the chance of getting severe COVID is worth trying to decrease the chance of long COVID.
Could you elaborate on that, the comorbidities, the things that make were more
Yeah,
prevalent for
so-
people who really got COVID very badly, had very large impact on their health?
Yeah, well, so do you mean the relationship between getting severe
Existing heart
COVID?
disease, obesity, smoking.
I think all of those things lead to increased chance of getting long COVID because they're going to have more chance of getting severe COVID. So yeah, lifestyle often has an impact on many diseases. Yeah, but after a couple of years of not taking care of your diabetes or having bad food choices and getting coronary artery disease, it all has an impact.
And just to clarify, did you say, when you were talking about the masking, there's no data on the necessary viral load for infection or severity?
So it's the minimum. It's the minimum. So in other words, you're sick, you're coughing, you feel bad, there's lots of virus coming out.
Right, but we don't have any data on how many virus, virion does it take
Yeah,
to make
so-
somebody sick?
So in other words, to change what you're saying is, what's the minimum amount of excreted virus to cause infection?
Yes.
You don't know. It's low, and it's probably fairly low, but there's probably some level below which you won't get infected. But a lot of that has to do with how long you're in contact with that person. You know, what space are you in? How much ventilation is there? So that's one of the reasons we can't really tell you an absolute number, because it depends on exposure time, environmental conditions. You know, humidity in the air can make a difference. That just is very important. So, there is probably some level, but it's hard to calculate unless you can get the conditions to be identical. All right, you may see something in the news about Paxlovid not being as effective as it was, because they're looking at a data set of the people who are at risk for hospitalization, and they take Paxlovid versus the same type of people who don't take Paxlovid. There's still a difference in the rates. So if you don't take the Paxlovid, you like a higher rate of name. But the old data that they're comparing it to was pre-vaccine. So, and also with more serious strains around. So the old rates really aren't comparable to the new rates, but it is good to know that the new strains can be ameliorated. The disease created by the new strains can be ameliorated by Paxlovid. And remdesivir is still active, which is the inpatient drug that's used. If patients come into the hospital, they get remdesivir right away if they're at high risk to proceed to severe illness or ventilation. So we still have those in the toolbox, but some of the data is difficult to interpret because of the comparisons to previous outbreaks. Any questions about long COVID vaccines? COVID outbreaks?
Are we expecting a flu season this year?
Oh, yeah. Yeah, I've already got my flu shot. So, yeah, that's not gonna go away. goes
Well, it
up.
did for 2 years, so I just want to know if it was gonna come back.
Lou, yeah,
Mhm.
I don't know if anybody's reported yet. Melissa, you usually have any.
We have a long-term care with the flu outbreak.
Yeah. All right, and the last thing is, we were talking about the fentanyl, it's really interesting. So there's always people looking for recreational drugs, and opiates have been around for, 100 plus 200 years, I mean, it goes way back. The opium poppy is the source of the resin that makes the opium. And heroin, which is derived from opium, it's rather expensive to make. I mean, you gotta raise the poppies, you gotta farm them, you gotta hide them from the authorities. Then you have to purify the resin, and it ends up being a white powder. And that white powder is given the cartels buy it or make it, and then they cut it. Right? They cut it with all kinds of things. Cocaine, they cut it with all kinds of things. Whatever you can get your hands on, they cut it. And so there's this kind of population of people that have addictive, sort of underlying medical propensity to become addicted. So there's always going to be addicts around. And what's happened with the fentanyl is it's turned sublethal and non-lethal preparations of recreational drugs into lethal. And so there's an underlying situation in society that hasn't changed, but the drug has. So the behaviors that lead to addiction and use of opiates have been changed dramatically by the introduction of fentanyl, which has been around. It was invented in the 1950s, and it was invented to provide pain relief over a short time in the hospital. So if you underwent major surgery, you could use a little bit of fentanyl and get a lot of pain relief, and then it predictably wore off. But that's because we knew exactly what the potency was and exactly what the dose that was being given. So now this is being snuck in by the drug dealers who are cutting other stuff, whatever it is, if it's heroin, if it's cocaine, whatever it is, they're cutting with fentanyl, and the effect is huge. So they can use less of the stuff that's expensive, like heroin, and get the same effect with a little bit of fentanyl. Problem is, there's no dose control and potency control.
Yeah, isn't that the other issue, is that they're making it much more potent than the medical use?
Oh, yeah,
Fentanyl.
yeah. Yeah.
So, yeah, when people hear fentanyl now, they're thinking like what you get in the hospital, and it's not even close.
Yeah, everything that you do in the hospital isn't being done by the dealers. So, the way that the dealers and the cartels are making this happen. And how do the cartels get a hold of it? The fentanyl's making money. And it's not just, you can't like trash the Chinese. It's actually illegal. Fentanyl's illegal to distribute and to manufacture, other than for medical reasons. What's happening is the people that make it change the molecule a little bit, so that it's no longer the fentanyl compound that's illegal. So there keeps being these little modifications in the fentanyl molecule. Who knows, maybe it makes it more lethal too. But that's coming out and being distributed through the already existing drug distribution network. And the problem is people get this bad stuff and they end up ODing. So it's the front end and the back end. You need both sides.
Can you clarify your comment? You can't trash the Chinese? What?
So you can't, if the Chinese government isn't completely, it's not complicit in the whole thing. It's that their laws don't cover the new compounds that are being made. They could change it, but to as far as.
I think I would argue they're absolutely complicit
I agree.
Well,
for many things. If it's leaving their border, they're complicit.
I will let you go with that as far as you want. That's out of my realm. So that I just want to do that. And then one other comment that came up about food inspectors. You're going to talk about the Shigella issue. So those two things are linked pretty tight. And with that, if there's no questions, I'll end my report.
Thank you, Dr. Barg. All right, then we'll move to Melissa Sickfried with disease control.
Okay, good morning. I'll just finish up with COVID really briefly. We are seeing an increase in our cases. We have over the last month or two. Our case rate as of yesterday was 107, which we haven't seen since probably February to see it that high. We have 12 long-term care outbreaks right now with COVID outbreaks. One of those was also a flu and COVID outbreak. So flu is definitely starting to come into the community. We are starting to get our we've requested our flu numbers from our hospitals. So over the next few weeks, we'll start getting our numbers as those come in. And those are lab confirmed cases that are tested by the hospitals, all 3 hospitals here for Yakima County, and we'll keep those flu stats up weekly on our website. Testing kits are available again. Lillian probably has a little bit more information on where you can go to get COVID at-home testing kits, but those are available again by the federal government. I also wanted to talk on Shigella. We've reported for the last couple of months, we're having an increase in our Shigella cases, which is it's an enteric or a bacteria that causes nausea, vomiting, diarrhea, sometimes bloody diarrhea. It's highly transmissible and usually spread person to person. We've noticed an increase a couple of months ago. We weren't able to identify any links to a specific food item or food establishment. They were just popping up here and there. We have had several cases come out of our homeless shelters, which is concerning. Just for reference, last year to date, we had 9 cases of Shigella reported. This year we have 57 year to date. So we've seen a huge increase. We've done provider education out at the local shelters. We have sent out a provider alert to the providers in the community. And we've also sent letters to all restaurants to remind their staff not to be coming to work if they're having any symptoms, frequent hand washing, all those things, because once you get into a restaurant or a food establishment, it's incredible. I think I spoke a little bit on the flu. We started up a provider monthly provider meeting. So we bring together invited all of our FQHCs, local clinics, hospitals to come together and on Zoom have a meeting to just discuss any updates we're having with the health district. Dr. Barg was on that meeting. So that's something that we're going to be doing monthly to engage our providers, in addition to our provider resource webpage that we have for them, but just to be able to provide any updates on emerging issues within public health. And also our child death review for Commissioner Curtis. That's a program that was actively running several years ago. And then as staffing decreased, we just didn't have the staff and the manpower to do that, especially during COVID. But it's something that we're starting up again that Jackie's helping me with. We are identifying all of our stakeholders. We hope to have a first internal mock meeting in November and then start up the first of the year with using our stakeholders, which could be individuals, the coroner's office, maybe the police, chief of police, CPS, whoever might be involved. And I think we've identified our first cases that we'll be looking at is suicide, because it is something that higher in the community from COVID. So our cases are the first ones that we do a case review. And the purpose of this is to take these cases, bring everybody together, see what happened and how we can prevent those in the future. So Andre and I like to call it, it's not necessarily child death review, but child death prevention, to look at initiatives that we can come up with to prevent child death in the future. And that's all I have, unless there's any questions. Any questions?
2 questions, Melissa. First, the #1 prevention for Shigella is hand washing. We should just reiterate that. More comment. Number 2, the suicide death increase, is that specifically in children or is that across the valley?
So it's across the valley, but we are looking at the child death review is specific to anyone under the age of 18. So it can be anything from an MVA, chronic illness, suicide, any child death. We are going to be looking at those and trying to come up with initiatives for prevention.
And then for stakeholders, if it expands beyond children, the Veterans Administration would be very helpful, I'm sure, for suicide prevention and various things that they're doing to try and stem the tide of veterans committing suicide.
Well, we're writing that down. Thank you.
Any other questions?
What kind of tests are they still using the PCR test in the hospital for COVID?
They're not doing any testing in the ERs or on admission unless you were coming in for symptoms like COVID, but they're not doing the routine testing anymore.
So there's no screening. So it'll be specific syndromic testing.
And it's still the PCR.
Still available. And lots of people are doing rapids at home and they don't get reported, which is why the wastewater screening is really important.
How do those tests work? Because they're different than the PCR, correct?
Oh, yeah. So it's called a lateral flow assay. So you take stuff from your nose and you put it into a little tube and it breaks it down so that there's certain proteins present. And then the little piece of strip of paper that's in there has a indicator on it, and it will trap COVID proteins. So as it moves through, it hits that little strip there, and that's what turns pink. So there's two strips. If you're positive, there's a control strip that says C on it. Then there's a T strip. So if the C is positive, T is positive, you got COVID.
Is there any way that we can find out the cycles that the hospital is using for the PCRs?
You know, you had asked that before and they don't. That machine doesn't give you the cycles. And it's nice to know, but I think when we're not in the kind of outbreak and death rate that we're now, it's not, that their machine does not give them the cycle number.
There's no way to find out from the manufacturer or anything?
I don't know. Some machines do. So the
Yeah.
cycle number that Delene's referring to is how many times the PCR cycle has to run before they detect it.
It's exponential.
If there's a lot there, then the cycle counts small. And if there's very little bit of there, then the cycle counts high. But it doesn't really tell you, again, for like just for the virons from culture, we don't know what cycle level is absolutely, correlates with infectivity versus non-infectivity. In fact, the PCR can stay positive for weeks and weeks, but the patient not be infected because you're not measuring active virus, you're measuring virus pieces.
Right, which could be dead viruses from long ago.
Well,
And
not
the
that
more
one.
you cycle it, the more you pick those up and gives you a false positive. So that's why it's crucial. And there was a lot of information about that.
No, we talked about that at length. I know.
Dr. Fauci during the time talking about the cycle thresholds. And, beyond a certain number of cycles, it really was erroneous and irrelevant data because it gives false positive.
My guess is they're going to have cut off. And if it doesn't get positive, if it's more than a certain number of cycles, then they don't consider that a positive. So it's like, there's a lot of other tests that work the same way. So you can get signals on tests. They look at population studies and they develop a nomogram. So below this number, even though there might be a signal, it's not correlated with disease. And above that number, it is correlated with disease.
Right, yeah, and there's information around that actually from the inventor of the PCR and how it should be used and not used. And so is there any way I could talk to somebody or
drop
the
down-
board could
drop
access
down the lab.
the lab
So
and,
done in micro.
okay.
Dr. Berg, a little bit unrelated, but you bring it up, and because I don't know if it would be Melissa, or it might even be Sean, but you mentioned the water treatment testing, which has been a tool that has been used, to look at mass outbreaks across the US. And we just have started testing for PFAS in Washington State. And I wonder if it'd be interesting to have a presentation on kind of the history of water treatment testing and what we do and do not test for, and a little historical relevance to not only are we testing for COVID right now, but we test for hepatitis, we test for all these things. And it'd be interesting to see the prevalence of other diseases simultaneously that we don't hear about as much as COVID. But it'd be interesting to have a little history lesson on what we test for, what we don't test for. And
Good job for Sean.
I know.
He doesn't have it.
Into it.
It sounds like a special board presentation.
Yeah.
So yeah, I think it actually would be kind of interesting to put that together and see. So there may be a much larger pool of things that can be tested for than are currently being tested for, but that should be about. But yeah, we want to know.
And just so we've had testing on municipal water treatment facilities in the county now, and so far, no municipal treatment center has tested positive for PFAS, but.
We'll look forward to spotlight, John.
What Dr. Barg is referring to is wastewater that they're testing.
Yeah, not water supply. But wait.
Yeah, excuse me, yep.
Any other questions for Dr. Mark?
Or Melissa.
Oh, I'm on the list. Oh, Melissa, we're on. Passing it on to Sean.
I think it's him.
Then we'll move on to local emergency response. Andrew Wilson.
Morning, we had one response this month, the natural gas explosion down Toppenish last Friday. After that, or before that, on the 13th, we participated in the Yakima Air Terminal functional drill. It's a really good drill, got to work with a lot of agencies there, see how it all works together. Next year in May 11th, they'll go full scale. That'll be a good drill to do. We have demobilized ICS for DTG. We're going to continue with the work group that will meet weekly as they continue their work, but ICS is officially demobilized. And YHD is gonna participate in the Great Shakeout this month or in October, which is a national evacuation, based around earthquakes. So we're gonna do that on 10/17.
On one again?
10/17,
Thank you.
and that's it for me.
Any questions, Randy, this morning?
Just the comment that someone did lose their life in that explosion. It's very tragic, and we certainly want to send our prayers out to the impacted family members.
Thank you, Commissioner McKinney, for that. All right, then we move on. Environmental health, Sean McGee.
All right, good morning, everybody.
Pretty quick, right? You don't have any.
Yeah, I can't leave you guys off like that. So starting with our two LPLs, start with DTG on their permitting process. The public comment period for their clean air permit is underway. I believe in the next 2 to 3 weeks, there'll be the hearing for public comment regarding their clean air permit. All signs so far point towards that permit being able to be issued by Clean Air. I don't have an exact date as to when. But the other compliance issues that were involved in the decision to deny permit renewal have been taken care of and resolved. So once they have a clean air permit in hand, they will be eligible to have a new solid waste permit issued by YHD, and they'll be able to operate the Lemon River landfill once again. And update on the Caton landfill, currently still operating. I think they don't currently have a permit by YHD. And we're still going through the appeals process for that permit, denial of the permit from there. As they filed with the pollution control hearing court. So that's where we're at with Caton landfill. We'll continue to keep working and trying to make progress on that facility as well. We're entering school season, so we're starting up with our school inspections. So it's our kind of fall, winter, spring seasonal inspections we have on the docket. So we'll be in our schools and doing our food inspections there.
I have a question.
Yes.
Do you time it when it's cheese only day?
They're not the same.
Ryan's shaking his head. I think. He uses potatoes and goats.
I mean, I'm not gonna tell you how to do your job, but you might want to consider that.
Need to take a sample. Quick update on the Mabton water system. So testing results for the Mabton water system came back as the water is not contaminated with anything imminent public health threat or anything like that. It is safe to drink. There are some issues with the odor and taste that we're still hearing about. The systems operator, Valley Water Services, is in the process of securing equipment to run some further tests on possible gas that's dissolved in the water that could be contributed to that. For example, like methane, which has been an issue in the past for that water system, but it's not a health threat. But we're looking into that, and maybe them looking into how to increase the ability to remove gas from the water through aeration systems. Typically an adequate treatment of that. So we'll keep looking and working with City of Mabton and their system operator and assist DOH use the regulatory authority over that water system as needed with outreach education efforts.
Sean, it seems like they do have some level of aeration now, correct?
They do, but from what I've heard from the system operator, that it might just be time to update that and make it more robust, bigger, faster flow through. Just a more rigorous treatment system to get more gas out. We'll see what happens there. They are completing the drilling of 2 new source wells to help aid in the demand issues with that system during the summertime. They have to rely less on well number 5, which is the main contributor of the smell issues. Then that might also help solve the problem as well. But we won't know until those wells are online and connected and samples are taken. So we'll know more in the next couple months on that.
I think the biggest factor for people here is that it's not a health safety issue.
Correct.
It's simply an unpleasant nasal experience.
As right now, that's what it seems to be, but we're still monitoring the situation and involved as needed.
And those large municipal well systems are routinely tested and they've been rigorously tested.
Quarterly. One of the last things I want to touch on is related to PFAS and we have Group B water systems in our county. So systems that are 3 to 9 connections. So they're smaller public water systems that are regulated by the health district to a certain extent. The health district has no authority to approve treatment systems for those wells. So for example, if a Group B system was being developed, they drilled a well and they did their round of sampling before they can use that system and a primary contaminant was detected, the well's automatically disqualified from being able to be a water source for that system. What we are working on is a draft local Group B ordinance that if put into place, we would be recognized by DOH at the state level of having the authority to approve treatment system on Group Bs with primary contaminants. For example, any Group Bs that might be in the PFAS area that have detections of PFAS would need a treatment system, which is being provided by the Army. But we would have the authority to say, yes, this is adequate treatment for that system. The system can move forward and continue to serve people. So we're going through a vetting process of that draft ordinance now. And we hopefully may have a little time before the EPA makes a final decision on setting the new PFAS limits. I kind of got an update at the conference I'm at that end of the year might be a little sooner than what they're able to actually put into code or law. So we're just trying to be prepared for the ever-changing and evolving way we look at drinking water and water quality issues in our county. It's not an overnight fix. It's a long-term issue that we'll be dealing with and looking for long-term solutions and resources to provide.
A quick question on that. So when you talk about the, drilling for these systems or any well, do you have any feel for how often a well is drilled and it's determined unsuitable for water?
Not very often, I'm depending on the area. It doesn't happen very often, but there are 2 main areas we have concerns about: the lower Yakima Valley Guama for nitrates and the East Sela area for PFAS. And how much more these areas grow or new areas pop up with water quality issues, we want to be prepared. But all of our we have a lot of Group Bs in Yakima County right now that are operating without treatment because their water's testing clean. But with the introduction of PFAS contamination, we do have a couple that need that resource and that authority to be present to allow them to install treatment system. So we're working on addressing that and bridging that gap. It also gives us the ability to look at the sampling data and kind of get out in front of any potential contamination or movement of contaminations in groundwater and anticipate ahead of what could be happening.
If I may, Commissioner Lindsay, this is not just a health and safety issue, it's a land development issue. If you know that you're gonna have contaminants in water before you've even tested, then you can't develop that land for use for facilities or homes. So that's why we want to get out of it.
I would just like to comment and thank you, Sean, for being proactive, because it is a proactive way to get localized solutions and a much more expeditious way than what the state has been able to provide. But really, to that point, Andre, it's more important that, if there's water there and if it were not for one issue that could be filtered out very, very safely, it would be a potable water source. So I think it's just really great that you're working on. Thank you for it.
We'll have to pass that on to my staff because they worked hard on this and trying to make a very streamlined ordinance that can be implemented quickly if we're faced with such a situation. So I extend my thanks to my staff for working on it as well.
But that, for today concludes my.
Thank you. Questions? Hearing none, we'll move on to a public health partnership, Lillian Bravo.
Thank you. I'll just have two brief updates to reiterate some of the updates that have been given in terms of we're heading into respiratory illness season. So our website is updated. All of our team has called all the different pharmacies across the county to see who has the updated COVID and who has the flu vaccine and things like that. So that's the same website, yakimavaccines.org, or in Spanish, yakimavacunas.org as well. So please feel free to share that for anyone that's interested in getting their either updated COVID or their flu vaccine moving forward. On that list, it has information for both people that have insurance and those that are uninsured, what their costs would be. So a great resource for people, especially right now. I know that is people are interested, and we went ahead and made those calls already. And then the same thing in terms of accessing those at-home test kits. We still are using the same website, Yakima Testing, or Yakima. So they are still coming in handy. And then the other update is to reference with the breast cervical colon health program. We did end up overseeing some of the a lot of the Eastern Washington counties for the breast cervical colon health program after the Spokane Regional Health District decided no longer to move forward. And so just an update, we did think that was going to be short term, but at this point in time, they haven't found a local organization that's going to be taking that program on in the short term. And so we are working with the State Department of Health to continue to make sure that we are not only serving the residents within Spokane, but also doing our due diligence and providing outreach to some of the more rural counties like Ferry and Ferry County as well as some of those neighboring counties. So that's just some work that we'll be able to take on now that we have our program manager in place, which you all met, I think. So, and then finally, with the DD program, as was referenced earlier this year, the state legislature did approve enhanced rates for our developmental disability employment providers, which is great news for them. They were really struggling. And so that is reflected in some of the additional budget and money that we're seeing in the upcoming year. So that's it for me.
Any questions for Ms. Bravo this morning? Thank you. Then we will move on. We are now at unfinished business, the first being the 2024 public hearing.
So we did not receive any comments for the public fee hearing. I don't know if we need it or yes. We have no input.
Then we will just close the public hearing piece. Thank you. We have a proposed motion.
Yes, I'm not sure. I would propose that we adopt the 24 fee schedule.
But we have a motion and a second to adopt the 2024 fee schedule. Any questions or comments about that?
Hard to argue with no increasing them.
Well, just to emphasize the point, there was no increase.
Yep, exactly.
And we actually applaud the health district for that. So all of those in favor of the motion, please say aye. Aye. Any opposed, say no. Not opposed, motion passes. Thank you.
Thank you.
And we have new business this morning. The District Board Public Communication regarding COVID masking, and Commissioner McKinney wanted to share about that.
Yes, thank you. So I appreciate Dr. Bark's comments regarding masking, but I think it's important because I have been noticing that there's some schools in some parts of states, different universities, elementary schools, businesses that are requiring children and adults to mask to be able to enter and attend school. I unfortunately think that, it's very clear that we have had a mental health crisis that is caused by the COVID response. And there are plenty now masking studies that have come out. I would just say that inconclusive is the best way to describe the cumulative number of reports and whether or not masking is effective. I think that Dr. Bark hit it right on the head. It should be something that is a personal individual choice. If you believe that you are going to wear the type of mask in a manner that is going to provide you some protection, that should be your choice. But it is very clear that mask wearing, especially cloth masks on children in schools, did nothing to help with the spread of COVID. It still came, it's still with us today. It's going to be with us for decades, I think is what Dr. Bark has actually in previous reports has said, that this is something that will be with us for decades and decades. My concern is that it seems that public communication on that has been, at least from the public health standpoint, very contradictory to where people really feel they're at with COVID. And we seem to be losing people more in their belief in what public health can do to help with prevention. And I think we're missing the mark if we're going to continue to be telling people that they need to mask up. If we're not at least citing that it should be voluntary, and that explaining specifically what types of masks and how to wear them, and other activities that need to go along with it, such as practicing sterilization, hand washing. I thank you, Dr. Atterbury, was something that you brought up. But I just want to make sure that we're discussing this as a board. I do not want to see Yakima County have any kind of communication that would require and mandate masks. And that is why I'm raising the subject. I think that we need to make it very clear to the community where the health board stands on this. And I wanted to bring it up for dialogue.
Thank you. Do we have any questions or ongoing discussion? I do have a question if anybody knows. Is there any school or facility in Washington state that we are aware of that is mandating masking at this point?
Not today.
Okay. I haven't heard either, so
there's, my uncle's in a nursing home and they've had some COVID outbreak at the nursing home. So when you go to visit, they encourage you to wear a mask and sanitize your hands. I don't know that it's mandated, but it's.
I can share that the discussions that have been coming about mask use have really been primarily about medical facilities caring for older adults or those who are immunocompromised. So thank you for bringing it up. That is the concern specifically. But again, that's still recommendations. There are no mandates, no restrictions, nor has there been any discussion of that at the state or either federal level.
No, I just like go ahead, if I may, just kind of gather too on that note, as far as the medical facilities that, you know, if we start moving towards a point of talking about or implementing mandatory masks in the medical facilities, I really have a problem. I mean, there's a lot of data out there now that shows the ineffectiveness of masking for an airborne illness. I mean, that's what we had to do yearly education on for years and years. And SARS is still listed as an airborne illness that is not mitigated by cloth masks. It said that during COVID, during my health stream education that I had to do every year. But we need to really keep in mind when we think about making decisions like that, the impact that it has on patients and families, to keep families away from their sick loved one is criminal. And we need to be very careful about going down that road again. Sick people need their family and loved ones because sometimes they're so sick they can't advocate for themselves. And they need to have the people that care about them most, they're advocating for them and asking questions. And, you know, when you're sick, a doctor can come in and give you information and this and that, and this is what your tests show. When you're sick, you can't remember that. And you can't convey that to your family if and when you get to talk to them. So please, please, you know, let's keep that at the forefront going forward if we get into that discussion.
Yeah, I would just add my 2 cents into the conversation. You know, and of course, I've had this conversation with Mr. Fresco as your buyers. You know, there is a place for, in the public health realm, of course, for recommendations. Frankly, I think we welcome and need those recommendations, but I do share this, you know, the line that's crossed when we go from recommendation to mandate. I'm really quite happy and pleased to hear that, you know, with your conversation with the state, that they're not talking about mandates. I hope that continues. We have been, well, one, if we went back to mandates, I don't think the public would stomach it. I think there's some people that just got a bad taste of it. And part of that is because of the negative side effects we had, you know, because of the masking requirements in some circles. I think, Baleen, as you mentioned, sometimes in healthcare, there's certainly a place for masking, of course, in healthcare. But when you get into the families and you know, some of the inability to communicate in the isolation, it's an issue. I worry about our school children. My wife sat on the school board in Sunnyside for the last 12 years and saw some really negative effects from the mandatory masking in the schools, in that you know, some kids that are trying to learn English, for example, can't see someone speak and enunciate, and that's a problem if they're learning that as a second language. The other issue is that she saw even after the pandemic that kids, particularly in a middle school or teenager setting, that because they didn't think they were attractive, they would sometimes want to hide their face and they wouldn't want to take their mask off. And it's just kind of some kind of sad side effects there. So I'm all for the idea of recommendations. We welcome and need those, but I'm not a fan of the mandates and really don't want to go that.
I will share also that I am a supporter of personal responsibility, personal choice. And I think it belongs to the parents and adult individuals in terms of making those decisions in their lives. And I would support the state in their non-mandate stance and working with recommendations so that people can evaluate themselves, their health, their situation, their family situation, in terms of making a personal choice about masking. And I will share also in response to you, Darlene, that I was mayor of the city at the time that this took place, and I had many personal contacts from individuals who had family members in the hospital or in the nursing home who couldn't even visit them with or without masking. You know, it was a terrible situation that people were isolated, even people dying away from their families. Personal friends I've had who had family members die away from them because they weren't even allowed to go into see them in their health situation. So I would really detest the idea of us moving into that situation again. It was emotionally traumatic for the person dying and for the family members who lost them. So
I appreciate those comments. I think the reason why I wanted to bring it up, though, is specifically it's public health communication. That's my concern. The public health communication has created an irrational fear, a completely irrational fear among most people about COVID, how it will impact them individually, whether or not, when you see a 14-year-old child walking down the street with a mask on in the middle of winter by themselves, that is why we have a mental health crisis. The communication that is constant on this front has created this mental health crisis, and these children have irrational fears of this virus. So I think that we have to really thoughtfully consider the communication, because we will perpetuate that irrational fear. We've talked about the data. They are not at risk for having major illness due to COVID, even less now than they ever were. And so I really want to stress upon the communication should be focused on personal choices, cleanliness, prevention, and let's stay away with the idea of telling 16-year-old kids or children with 4-year-olds that they should really be masking their children to protect themselves even more. That's what I wanted to talk about. The communication matters. We're creating a mental health crisis still when we communicate this.
Commissioner McKinney, I just wanted to add that I'm an advocate for us to follow suit with New York State in trying to reinstate jobs for people that lost their jobs as a result of refusing to get vaccinated. That is an obscene position. It should not happen in healthcare. There is a national shortage of nurses. There's a national shortage of doctors, and getting rid of people because of a lack of vaccination is lunacy. It's not in the interest of public health. It is not in the interest of people, the citizens of the state of Washington, and specifically the people of Yakima County. So I still put a position out there that we should be advocating the state to reinstate jobs of people that were lost because of vaccination status. These are measurable numbers, and it's having a direct negative impact on the population of Yakima County, and that's what we're here to serve. So just my 2 cents.
And Commissioner McKinney, just to clarify, I mentioned earlier that we are preparing for respiratory illness season, and I just want to emphasize that that entails the stay at home when you're sick, get the vaccine if you're eligible and you're willing, and doing the safe hand washing practices. So that's the extent of the communications around respiratory illness preparation and prevention.
When you say to the public, based off of the effectiveness of the vaccine and what we know that the impact of COVID is on children, or in this case is not, the average person who sees that scroll through Facebook and sees that the health district is saying you need to go vaccinate your 6-month-old child, how many people in America have gone and done that?
I don't have that.
It's a very small number. To be credible messengers, we need to have a message that is resonating. So I guess what I'm saying is our communication is off. Continuing to tell people that they should do something when they're not doing it should give us pause and say, wow, just this blanket message of go and vaccinate your 6-month-old it's not resonating with people, and it makes them distrust. So if public health wants to stick with that message, I guess what I'm saying is pick a different message. Pick something else. If you encourage them to talk to their doctor, if they're concerned about COVID, if you think that someone in your family is absolutely potentially has a significant types of health issues that would cause them to be concerned about really truly getting sick because of COVID, even now, encourage them to go to their doctor. But just scrolling through Facebook and seeing all these go get vaccinated, go get vaccinated, go get vaccinated to 6-month-old babies when we're dealing with all these other issues, it's to me, it is a waste of the voice that we could be using to encourage people to make decisions that I think are going to contribute to what we want, which is that we're wanting people to voluntarily choose to do things that are as simple and really what we learned in kindergarten. If you're sick, don't go to work. Don't drop your kids off to school. We know it's an inconvenience. So maybe if it's, hey, if your children are sick and you don't want to take them to school, but you don't know where a childcare service is near you, we're a resource for you. We'll point you towards where you could potentially get childcare to help you with that. But help them make a decision that they know is right voluntarily. We're missing the mark. The more we do that, the more people are tuning it out. And that is evident by the lack of people who are getting vaccinated, and especially people who are not vaccinating their young children.
Yeah, and on that note, I mean, how about putting a messaging and information out there that include more than one narrative, more than one-sided? Like Commissioner McKinney said, just vaccinate. How about vitamins, diet, alternate medicines, instead of censoring the other suggestions like has been going on and the government has admitted? Why don't we allow both sides? I mean, that's true science. True science is debate and offering other, evidence. And that's been censored. So we need to, give people all the information and let them make the decision that's best for them.
I would share that we continue to follow recommendations from the CDC and the state. One of the issues that we're concerned about that we're facing in Yakima County is the fact that we have a closed large hospital. So the concerns about vaccination is not just vaccination for COVID, it's the reality that flu is a serious issue. We have RSV. There is concern, and it's been something that's been discussed at length on the west side on what's referred to as the I-5 corridor, but the concern that emergency rooms and hospitalizations could be affected by having people who become ill with diseases that could be prevented. because of vaccination. So we are in a health professional shortage areas, which refer to a place like Yakima County where there are not enough clinicians to provide services. We have a closed hospital. We really have a reduced healthcare system. We also have concerns because ambulance coverage is hard in a large county and referrals to other hospitals are down or not being allowed. So the concern is that we want to remain vigilant so that the integrity of our medical system is not impacted in a crisis that is affected by seasonal illnesses. That's one issue. The other issue I did want to share is it's no doubt there have been mental health crises, but I do want to be very candid. We've lost a lot of people to COVID in over 1 million deaths in this country. The impact of mental health was not just concerns around COVID vaccines or masking. There's the loss of loved ones. There's the loss of people who were the primary breadwinners and their families. There's the loss of elders that we cared for who died unexpectedly or without care, as we know. It certainly is the realities that death or long COVID or the inability to work, we've been talking about employment, but those who are impacted physically, who have physical jobs, who make money with their hands has been impacted. So there's tragedies all over. And I share candidly with you that it's not just restrictions that cause that, it was death. So we want to be very honest about the fact that our community is impacted with mental health crisis. We have people who are really dramatically impacted. That's one of the reasons we're so committed to working on how to prevent things like suicide and certainly mental health concerns. So it's a long process. I recognize that it's a varied process, and there's certainly strong opinion on both things. Our goal is to provide evidence-based information to allow people to know.
I appreciate what you're saying, Andre, and I'm not advocating for not advocating for the health district to say do or do not. What I'm saying is we have the ability to be targeted. It is, the message can be, if you are particularly vulnerable because you're overweight, you're obese, you have heart disease, you have a loved one who's extremely ill or in the hospital and you want to visit them, you may want to talk to your doctor about what vaccinations and what other treatments are available to you without putting them directly into go get vaccinated for COVID, everybody. We have the ability to be targeted. And I think that's what people are really asking for. It's this one size fits all approach. And we can be targeted. We can say that we know that there are people who are more likely to develop long-term COVID based on what we just said. So why are we not taking the opportunity, I think, to show that we can be smart, we can use science and data, we can be strategic in our messaging. And that way people don't appear, because they're just scrolling by, and that's my concern. I'm not for or against anything other than the correct message, making it to the right people where it will resonate. I want them to actually go to Dr. Barr and talk about their personal situation and the ones that are impacting their own family members and have him give them very catered cultured advice about what is going to be best for your family. And I think that that's the resistance comes from people saying it's a one size fit all. They don't think that it applies to them. In fact, some are convinced it doesn't apply to them. And it appears that we're not sending a message. So I'm just, if we want our messages to resonate and they're not, then I think it's fair to say, why aren't they? And how can we pivot to send a type of message that will be well received?
Well, I'm encouraged by any conversations that allow for more education for people and certainly the advice of those who are trained and expert in the area. So I think that's wonderful. And I think we can incorporate that.
I think that is kind of a, thank you, Commissioner McKinney. I think that underlying all the things we shared personally and experiences, a great deal that has to do with encouraging people to talk to their health directors, talk to their doctors, you know, about their own family, their own situation, and to make a decision based on that.
And Commissioner McKinney has recommended that everybody go see Dr. Barr. You're gonna be really busy. With him.
Not in the emergency room, though. We don't need to clog up the emergency room.
Any other comments? All right, thank you. I think, Commissioner McKinney, you had something else you wanted to talk about?
Yeah, Commissioner Lindsay.
I'm sorry, yeah. I was reading the name.
Yeah, just really quickly, I've noticed that, like a year or so ago, we had 3-hour health board meetings, and when they were kind of shortening, and we we decided we would schedule that down to 2, and I've seen the last couple of months, our time's expanding up to that 2.5, 3 hour limit again, and for me, for scheduling purposes, I think if we're gonna have 3 hour meetings, it'd be good for us to block out that 3 hours of time.
I think we started doing the community spotlight, which is added, and I think it's a value add. So I would agree that I think going back to at least scheduling for 3 hours makes sense as long as we have a community spotlight for the community spotlight presentation.
Sure. I also add candidly that the executive session is at a time.
That's
Well, that's true too. That's true.
But I
That might be
do,
going on.
but I do understand for scheduling purposes, the idea of a lengthened time certainly.
Yeah.
I've been marking 3 hours of my calendar regardless.
Me too.
All right. So thank you for bringing that up, just to make all the members of the board aware that in the future, we're likely going to, with executive session and ongoing wonderful spotlights, that we're likely going to extend into 2.5 to 3 hours, so.
Yeah, it'd be nice to have that blocked out.
Is there any other new business by the board? Right, we have a motion to adjourn.
Second.
So we have a motion and a second to adjourn to the next regular scheduled board of health meeting, October the 25th, 2023. All those in favor say aye.
Aye.
Then we are adjourned. Thank you.